First, we'll talk a little bit about the problem, some of the anatomy that's important to understand, how you pick it up clinically, and what imaging is needed, some strategies for managing the radial head and DREJ as we saw earlier today on the case that was just presented. So the problem is this forearm that we have where two bones move on each other is exclusive to humans. So the other primates can't rotate the forearm. They have one big radius ulna like a tibia fibula. And the goal is you want to put the hand in a position of function. And what you'll notice is people can live with a stiff wrist, right? We can fuse a wrist, but people don't tolerate loss of rotation very well. So that becomes quite frustrating. And although it's called Essex Lopresti, it was first described by Brockman, who published this paper in 1931. And what he said was subluxation of the inferior radioulnar joint following excision of the head of the radius. So they took the head of the radius out after a fracture. In those days, the only treatment was take out the broken bone, and the DREJ became unstable. So he was the first one who said there's some connection between the radial head and the DREJ. And Essex Lopresti, more famous for his description around the heel and other things, calcaneal fractures, after he died, they published his paper. After he died, and they said he had these two cases of a radial head fracture with DREJ dislocation. One was this one. The patient had no pain. They took out the radial head because of arthritis, and then he started getting DREJ pain. And if you look at it, his radial stump is now hitting the elbow, and the ulna is become long. So Essex Lopresti was probably not a good surgeon. They wrote these papers after he died. These are his complications. Maybe he wasn't writing it when he was alive. He didn't want to publish it. This was the other patient who had had his radial head excised and was getting pain at the DREJ. So the two cases made it clear that there is a connection between a radial head fracture here and a distal radioulnar joint, and the only way that happens is if the intraosseous membrane is completely torn. So how common is it? We are not really sure, because we see a lot of radial head fractures, right? Not all of them end up with Essex Lopresti injuries. So what people think are about 10% of radius fractures may have it, radial head fractures. Michael Hausman from New York did an MRI on all radial head fractures. When they did MRI, 60% of radial head fractures had an intraosseous membrane tear on MRI. So it's probably more common, but usually we seem to get away with it, right? That's what happens. So people do heal. So what we know about the intraosseous membrane is that it's got a lot of different fibers, but the most important fiber are the central band here. And these fibers run at a 21-degree angle from the radius to the ulna. It starts exactly where the pronator teres inserts. So your pronator teres muscle inserts here. If you take that point and you draw something 21 degrees down, that's where the central fibers, the most important fibers, run. And it is a very thick ligament. So what it does is it transfers the load from the radius to the ulna. So if you look at the load transmission and you look at the overall stability, it's like an ACL. So the knee joint, it's like a knee joint. Proximal radioulnar joint, distal radioulnar joint, and the central oblique fibers. That's how it kind of is constructed. So normally when you pick something up, 80% is in the radius, 20% is in the ulna. But when you get to the elbow, it becomes 40-60. And that's because the load from the radius is going into the ulna and then it's going up because of the intraosseous membrane. If you cut the TFCC and you cut the intraosseous membrane, the same load goes through the radius, keeps going through, 80%. So they get a lot of pain at the radiocapitellar joint. If you take out the radial head, all the load goes through here. And normally, your radius migrates 7 millimeters. So even with an intact ligament, if you cut the radial head, people will migrate about 7 millimeters. and all the load goes through here. But they don't get pain because the intraosseous membrane stops the radius from hitting the capitellum. If you cut the TFCC and the intraosseous membrane, that radius will keep going until it hits the capitellum because there's nothing to stop it. And the load starts going back through the radius again. So it's very painful. And the radius migrates by 15 millimeters, double the distance. So how do you get the injury? It's a fall on the outstretched hand and usually high velocity. So these patients present as a regular radial head fracture, but beside the elbow pain, they have pain in the forearm. So when you're examining these patients with radial head, look for pain in the forearm. If they've got pain in the forearm, pain at the DRUJ, you ought to be concerned. The problem is DRUJ pain may not be present initially. It will come after you take out the radial head. So that's why you want to be careful. So what are the imaging you need? You need elbow x-ray, of course. You need a wrist x-ray. So every radial head fracture where there's significant comminution, you need to do an elbow, a wrist x-ray as well. Ultrasound, it depends if you've got a good ultrasonographer. MRI, we don't tend to use it. We just look at the DRUJ, proximal radial ulnar joint, and we decide if that radial head needs to be fixed or not. So here is someone with this injury, and the wrist shows this injury, right? So this patient is very clear. He's had an injury at the elbow. He's had an injury at the wrist. This patient eventually ended up with the full-blown Essex Lopresti because the radial head was excised. So this is the ultrasound where this is a normal membrane and this is a membrane that's torn. But again, I don't use it. This is from the journal articles. MRI, again, I don't use it because I don't think it changes the management, but this is what it looks like. The most useful thing is this radius pull test. So whenever you've got a radial head fracture, under anesthesia, when you're about to do your surgery for radial head, you want to pull on it. And if you're going to decide whether to put a replacement or not, you take out the radial head and you put traction on it and you take an x-ray of the wrist. If you get more than a 3 millimeter change, your TFCC is gone. If you get 6 millimeters, then definitely your intraosseous membrane is gone and you should be replacing the radial head. So whenever you're doing a radial head excision for fracture, put traction on the wrist and take an x-ray of the wrist and see. If the ulnar is moving 6-7 millimeters, you probably should replace that radial head and not do an excision. Okay? This is another paper where they say intraoperatively, when you've taken the radial head out, put a reduction clamp around the shaft, and if you can pull the shaft out, the intraosseous membrane is torn. Right? So what can you do for the radial head? So they are never Mason 1, right? There'll never be a non-displaced fracture. They're always a displaced fracture. So if it's a Mason 2, we'll put screws in, and if it's more than 3 fragments, we replace it. You can put any kind of radial head implant you like. What radial heads implants are available here? You get like a monoblock, something like, is this what's available? Yeah. So then you look at the distal radial ulnar joint. What should you do for them? This is the one situation, intraosseous membrane is torn, where I may use radial ulnar pinning. Right? We talked about should we do it or not. This is one situation. TFCC repair, usually we do it when they come chronic. And Sauve Kapanji, what we were talking about, if they come as a chronic patient, that would be a reconstruction. So this is a little video showing the open TFCC repair. You can see the exposure there, and that's the TFCC we're going to repair back to bone. So I prefer these knotless anchors where we can put it back to bone. Now, if they end up with a late problem, this is the implant we tend to use, which gives them good, stable forearm rotation. This device is very expensive. It costs about $15,000 US. So what about the intraosseous membrane? What can you do for those? So we can repair it. We don't tend to do repairs. So we usually do reconstruction for late. So you'll see these are textbook pictures because we never see these patients acutely. So if I get a patient with a chronic Essex Lopresti, I'll replace the radial head, repair the DRUJ, and I'll replace the intraosseous membrane. So and then one technique is to use a pronated teres. The other technique is to use bone ligament bone from the patella or allograft. So that's how they put it directly onto the bone and fix it. Again, I don't have experience with it. I use a pronated teres, which I'll show you here in a minute. And sadly, when everything is really bad, then sometimes you put a plate between the radius and ulna and make it a one bone forearm. So here you can see the ulna has been fixed to the radius to lock it into a position of semi-pronation because they've had multiple operations. So here is an example. Bicycle accident in this female. And there's the distal radioulnar joint, right? So this is clearly an Essex Lopresti injury. So none of you should be able to miss this one, okay? So every radial head fracture should get a wrist x-ray. This is the normal wrist, this is the injured wrist, and you can see the step there, right? So that one gets a radial head replacement, and you can either put radioulnar pins or you can do a TFCC repair. So this is a treatment for Essex Lopresti. Radioulnar pinning or TFCC repair and radial head replacement. Okay? Even if your radial head replacement doesn't fit right, it's a spacer, you can take it out if they get pain after the intraosseous membrane has healed. 3 months later, 4 months later. But you want to put something there. Here is a patient who had a radial head excision, and he came to me because he's got pain over there. Right? So the problem is this. If I do a DARA on him, what will happen now? He'll get shorter again until his forearm will reach here because he'll keep cutting bone at both ends, right? So the answer is not to keep doing a DARA. So the problem here is he's got a problem there. So we put a radial head back for him. Okay? If you just put the radial head back and you don't address the TFC tear, they'll get a lot of load going through the radial head, so he'll get pain there. So along with the radial head replacement, you do a TFCC repair. Okay? And that's him. We put a radial head back, and his ulna has come to a good length, and he's happy. He's got back forearm rotation and wrist movement. This girl had a radial head replaced 4 years ago. The problem with her is they didn't repair her TFCC. So the radial head took all the load. So now she's got arthritis between the radial head and the capitellum. So now I can't replace the radial head. So I'm going to have to take out the radial head, but her forearm is going to get migration, right? So I need to reconstruct the intraosseous membrane. So this is a late reconstruction. So what we did here is took out that radial head, which was giving her pain. I put in some collagen. You can put in whatever you need or put in nothing. It doesn't matter in that gap. And you have to reconstruct the intraosseous membrane. So I take the pronated teres tendon. So the incision is made proximally and one incision on the insertion of pronated teres on the radius. So there's the pronated teres tendon. I've taken a strip of tendon from proximal to distal and it's left attached distally to the bone. Okay? Now it happens to be exactly where the oblique fibers normally run. So you take it from here and now pass it on the dorsal aspect of the forearm from there to the ulna at about a 20-degree angle. So you get a goniometer intraoperatively, measure the angle, and then you make a drill hole in the ulna, pull that through the drill hole and tie it down. So we've pulled it through a drill hole. We measured our angle, made sure we got it about 20 degrees, tied it down to the ulna. And that's her 1 year later. Because we reconstructed the intraosseous membrane, that radius has not migrated even though we took the head out. So the secret of success is, wherever possible, replace the radial head. If the radial head is arthritic, then reconstruct the intraosseous membrane. Okay? And that pronator teres tendon is very simple technique. Anybody could do it. It's not a complex technique. So what happens to these patients? When they come acutely, if you think they've got Essex Lopresti, if you replace the radial head and you repair the distal radioulnar joint by putting back the TFCC, or you put K wires between the radius and ulna, 83% are going to do well. So that's a good thing to do. This patient talked about 7 patients. Weighted that, all 7 were doing very well. This patient did bone, tendon bone from the knee. And that was for chronic ones. And now they've got pain at the knee. So we joke, if you want to take the patient from the hand clinic and get him out of the hand clinic to the knee clinic, so from me to you, we take patella tendon bone and get rid of them that way. This Allende talked about 7 patients who were chronic, and he did the 1 bone forearm. And those patients are pain-free, but they can't move their forearm, so they're not happy people. Okay. So if you look at this large series, 31 patients is a large series, right? Look at it again. 16 diagnosed early, 15 diagnosed late. So even in a center where they see a lot, 50% are getting missed. So we are all missing these every day, right? If they saw them early, the main thing is replace the radial head and pin the DRUJ. So the take-home message for you today is, if you see a radial head fracture and you see a DRUJ more than 6 millimeters, it's Essex Lopresti. Replace the radial head, pin the forearm, and you're going to be happy. Patient is going to be 80% happy. And a lot of people get reoperations, as you can see. So radial head fracture, and I've got a lecture on radial head fracture anyways, but we'll just say it quickly again. Assess the forearm. If there is no forearm problem, treat the radial head fracture. If there's a forearm problem, replace the radial head. If it's chronic, then you're going to have to do some kind of ulnar procedure and interosseous membrane reconstruction. So interosseous membrane repair is not done in the acute case, only done for the chronic case, okay? So to summarize once again, if you suspect Essex Lopresti, replace the radial head, do not resect it, and pin the DRUJ. If you see a chronic one, you have to reconstruct the interosseous membrane and the pronator teres tendon transfer 21 degrees under the extensor tendons onto a drill hole in the ulna will stabilize the forearm. Thank you.
Thank you. Thank you very much, sir. As we are running late, we can take 1 or 2 questions. There is one more talk by Dr. Gadegone, sir. 1 or 2 questions. Yeah, you can.
Yeah, can you give him the mic, please?
Yeah.
In cases of borderline DRUJ, when you give a traction and the displacement is roughly 3 mm, and it's Mason 4 radial head, if you don't replace the radial head and put the DRUJ pinning, would that suffice? In Mason 4 fractures, not replacing the radial head and
I think you can
DRUJ
pin it.
pinning.
Yeah, I think you can pin it. And it is possible that if the interosseous membrane heals properly, they will be all right. It's possible. But it's better to replace the radial head. But if you don't have a radial head available, then you can excise it and temporarily pin it, and that may work. I couldn't tell you because I've never done it.
Looking at the lateral elbow X-ray, it's just about similar as a Z effect. I mean, radius migrating proximally and ulna migrating distally.
Correct.
So if we block the migration, the radial proximal migration and the distal ulnar migration by putting pinning at the DRUJ level, wouldn't that suffice?
You're right. The pinning will suffice as long as the pins are in place. When you pull the pins out, you're hoping that the interosseous membrane has healed. Correct? If it's healed, that patient is going to be fine. If it hasn't healed, your backup option is you had the radial head in place. Correct? But if you didn't put that radial head, now you're relying on the healing. And if the healing didn't happen, he'll be one of those 20% of people who will be unhappy. So that is the worry. So if you do everything at the first go, you're giving him a better chance.
No matter, because the success rate of replacing the radial head is around 83%.
Correct. Yeah, nothing is 100%. It's a bad injury. You're right.
In meager resources, why not pin the DRUJ?
Absolutely. Yeah. I think it's better than just taking it out and doing nothing.
Yeah.
So what you're suggesting is a good alternative.
Yeah,
Yeah.
Padke sir. Yeah.
For the radial head, sir, do you find any difference between the monoblock and modular radial heads? And do you cement or use uncemented heads?
So those are questions that are not answered because nobody is clear. Because when you listen to Graham King from Canada, his implant sold by Wright Medical is completely smooth, and he says the implant should rotate in the bone, and it should rotate everywhere, and it should never get bone growth. It's a spacer. You listen to Sean O'Driscoll from the Mayo Clinic, he says it should be porous coated, it should be tight fit, and it should never rotate in the bone. Both of them write large series with excellent results because they both are selling different implants. Okay? So clearly, both options are good. Okay? So nobody knows for sure. So cementing is not necessary as long as you get a good fit. I think the importance is you get the right width of the head so you put the radius out to its normal length. I think that's the most important part. Monoblock works as well. It's hard to put a monoblock in, right? So these modular ones, you can put the stem in and then put the head on. It just is technically easier. And with modular, you can put different collar heights, different head diameter, so it gives you more options.
Yeah. Thank you very much, sir.
Yeah, so one quick question, quick answer, and then the last
So
talk.
of late, there has been a trend of intramedullary fixing the radial head. How far will it really help in preventing a Essex Lopresti?
I think wherever you put the radial head back, it's a good thing. And definitely the patient's own head is better than a metal head because metal head eventually, metal on cartilage will eventually give you trouble. There's no question, right? So I think if you put it back and you put those tripod fixation with screws, that seems to be better with than a plate. But I recently revised one which failed and I put a plate. So right now I'm in a plating mode again. Yeah.
Okay, so thank you very much.